My title, I think, is Specialist Doctor Children's Palliative Care and Community Paediatrics. I work in a district general hospital, so a local hospital, leading a local children's palliative care team where we work both with our colleagues over at the specialist hospital but also with our local children's hospice. The whole thing is about supporting children, and by that I mean babies, children, young adults and their families, and with palliative and end-of-life care. So we aim to support them in any setting they're in, and I think whereas people often think about palliative care and they think it's about dying and end of life, and it is about those really hard things, but for us it's also about enabling these children who we know their life's going to be shorter, really sadly, to live their life absolutely to the full and in the way they want to do the things they want to do, to be with the people they want to be with, in the places they want to be, and really for the medical care in that to take its place so that we're supporting the aim of them having real quality of life. Always a hard conversation, there's no avoiding that. I think for me trust is hugely important when working with a family and a child and young person, and that takes time, like taking that time to build up that relationship of trust and listening, so really understanding where they're coming from, what's important to them. And my job involves many conversations, and those have got to be compassionate conversations. So I think coming to it with empathy and with humility, just listening to where a family are. And often they've thought about things that you think, oh, they're not going to want to discuss this, but actually it has been keeping them up at night and it is on their mind. And actually what you need is the time, and good palliative care really does take time. And ideally I would approach that in their own home if I could, if they wanted that, but sometimes that's not right for people and they'll choose. So giving them the opportunity to kind of choose who they're going to talk to and when and where is really important. And often the conversations, although they sound so hard to have, are actually, they're already conversations that are on a parent's mind or on a young person's mind, and actually having the conversation feels so much better. And so often I'll go and talk to a family, I've done it just in the last few weeks, and actually they'll say, I am so relieved. I am so glad that we've talked all about that and you've understood it and we've got that written down in a plan. And I often feel that in my role, so working in a local service where there will be, every child has a multitude of specialists, which is brilliant. These people are brilliant, but I often see my job, and I was doing it this morning on a meeting, my job, the subject is technical, it's about a rare condition, it isn't my specialty, my thing is palliative care, but I feel my role is trying to get the best from all these people for a child, and that's often about trying to convey actually where are the parents coming from. So in that, I would always like to give parents an opportunity to be part of any discussions. So we're doing that this week with a meeting where parents will be in the meeting and asking their questions, so kind of giving them a platform, but also when it's not easy for them to speak in certain situations, really understanding what they want to ask and understand, and then taking that to the right people. Yeah, so important, because it's a partnership, and if you lose that partnership and that relationship of trust, and I see that happen sometimes in other situations, then you really have lost the ability to provide the care that we want to provide. So always working in partnership, I think, with families is so important. Really hard. When I did some of my palliative care training, someone who's now in the House of Lords actually, Professor Elora Finlay, she's an amazing woman, and she did this lecture for us, and I always remember one of the things she said was, you always have to find a hook to hang hope on. So everybody needs hope. None of us can live without hope. Nobody can survive without hope, but sometimes in these situations it's about transferring the hope to something that we can do. So sometimes a family, understandably and rightly in many ways, will be hoping their child is going to get through this, that they're going to get better, but we can understand that that isn't what's going to happen. And then it's so important to have those honest discussions, I always try and say to families, there's not going to be anything that I don't say to you, it's all going to be said, and we're going to have those hard conversations, but you can know that I'm always going to tell you everything, which I think is really important. But sometimes there'll come a point when actually that hope for a cure, we need to be transferring that to a hope for something else, and sometimes that's a hope to be together as a family. That's sometimes a hope comfort and not being in pain. And I've seen many families go through that journey, and I can think of families where there were points when I thought, we're not going in this direction, and we're not going to get to where you want to be, and I'm so sorry for that. I wish it were different. And I'm always honest. I say we're all hoping for the miracle. We are. I love it when children surprise me, and against all odds they get better. That is amazing. But when that doesn't happen, it's about finding somewhere else to land that hope. I don't think you can ever take people's hope away, but it's helping them with putting that somewhere in something that we can work together to do, and finding peace in that in the midst of a real struggle, and also reassuring them that we're not going to be going away, that our care will carry on into bereavement, and support them, with whatever's coming next. Yes, that can be hard. That can be hard because, understandably, for a family and for parents particularly, their emotions are strong, and their desire to fight for their child is rightly strong, and they do that, but they're tired, they're exhausted, and my heart goes out to them every family I look after. But I think it is very important to hear the child's voice. Sometimes they are children who have a voice, a literal voice, and they can say how they feel, and we need to be listening to that. I've worked with children who have sort of typed messages or written messages, and we've really tried to understand, what they're trying to tell us about the care they're receiving and what they want. But sometimes, and quite increasingly so, we're working with children who actually don't have their own voice. They've either never been able to speak for themselves, or they've lost that ability due to the really difficult condition they've got. And then I feel really strongly about this, partly because I have a brother who has profound disability, and he's never been able to speak. So I feel really strongly about that need for those who can't speak for themselves, really to hear them. And it is possible to hear them so sometimes with children it's about really spending time with them and understanding what their emotions and their behaviour and their responses show us about how they're feeling about things, but also about what they love, and giving them more of what they love, and again enabling them to live their life to the full. But it's not easy, and I think things are becoming more and more complicated. There's more and more that we can do in terms of medical things, but it's always important to think about, in this particular situation for this child, in this unique situation, what is going to be best, and really listening to them in that.
So, like I said, initially in conversation it got brought up around his wishes and what makes him happy, and then a couple of days after we got told he was end of life, we sat down with the palliative care doctors and decided to go through the form together, and obviously put the do not resuscitate in place. But it was really like a work in progress. They made it known to us that this wasn't the final draft, that we could make amendments along the way, and I think especially around switching off his pacemaker, it was, you don't have to make that decision right now. It is something we can look at a later date. But I think it was more so whilst we were in hospital, rather than bringing him back to hospital to turn it off, it just seemed more suitable to do it then. But yeah, they went into it really caring nature. They didn't rush us through any decisions that we had, and it was kind of an ongoing conversation as well. I don't think the ACP was ever fully finished. Like, I must have had about 7 copies at home. It was constantly evolving and changing, and later on down the line, like, we did discuss again turning his pacemaker off, but it was at that point it was like, actually his pacemaker's probably not going to do anything anyway if something happened. So yeah, it was just constantly changing and evolving to suit Romeo and his needs, and it was really useful going in and out of hospital with it because he had recurrent infections at home. We had that so the doctors could see what our choices were, and I remember probably about a month before he passed away. He actually seemed to have another infection, had a high temperature, and I'd spoken to the palliative care doctors, and I said, look, I don't want to take him to hospital for this, I don't want to put him on any more antibiotics, actually, let's just ride it through, and they were happy with that. And also when he came home, he was on ventilation at night, and we'd agreed sort of halfway through him being at home that actually that was making him more miserable, putting the mask on, and what is the benefit rather than it's not prolonging his life, it's just making him more miserable, and it was more managing the symptoms and making sure he was comfortable.
Thank you. And thinking about when you were at home, and what worked well and what didn't work so well, touch on a few things.
So I think at home, having our community nurse was really valuable. She came in probably a couple of times a week to see us, to take blood tests, and we had to do COVID tests for if we needed to go to the hospice at all. So she would be constantly coming in to do dressing changes and seeing us, and just generally seeing how Romeo is. And she was a great bridge to dealing with palliative care doctors as well. If we ever had any concerns, we could get on the phone to the palliative care doctors there and then, or arrange a video call with them. And at one time they did actually do a home visit as well, which was important for us because actually Romeo liked being at home and he was comfortable at home, and they can see him how he is in his environment. So that was great. And then she had to go back to uni, which was about a month before Romeo passed away, which was devastating for us because we'd built up such a close relationship with her, and she knew Romeo inside out. It was hard that we weren't going to have her anymore, that continuity of care. So then we didn't really have like a named CCN, it was more of a few different CCNs at different times we would see. So that was hard to accept at the time because it felt like we were in this journey together and we were going to see it through to the end together. It worked well at home, having the continuing care in place. That was really important, and especially as I was heavily pregnant as well, with the community nurses and the palliative care consultants, we managed to build those days up gradually so we had more help at home. And also just dealing with his symptoms. If I had any concerns or if he was struggling with anything, I knew that they were just a phone call away and we could manage it with medications. So I'm grateful we've had a lot of support at home and being able to care for Romeo at home, which was important for us because he didn't like being in hospital or in the hospice. He liked his home and his bed. So.
And would you mind expanding just a little bit on the CHC?
What's that the?
Your continuing healthcare.
Oh yeah. So we got the continuing healthcare probably about a week or two after we came home. So I know the doctors in hospital were working closely with the CCNs and getting that in place for us and ready for when we left hospital. And initially that was 1 or 2 days a week, just overnight, because he was on the ventilation and had these medications which were had to be every 8 hours. And then it gradually went up to 3 days and then 5 days. And a lot of the nurses were nurses that we had in PICU as well that knew Romeo, which was lovely. Just having people that knew him already made it really helpful, so we didn't have to keep explaining ourselves.
Sorry, I don't know that supported you.
So I think for me the key learning things is the importance of communication. There's been so much along the journey where as a parent things haven't been communicated to me properly. I mean, going from the beginning to not being told that he looks like he has dysmorphic features, like reading that myself, having to do my own research on it and not knowing who to turn to ask about that. Bedside manner is a huge thing, and being told life-changing news shouldn't be taken lightly. It shouldn't just be dropped at you at the bedside. You should both, as parents, you both have a right to be told together, and just a bit of empathy in delivering that news as well. I think they're two real key points for me. And again, with his aspirin as well, I shouldn't have had to keep chasing and chasing. I mean, in the end, we were dealing with 4 different hospitals, and eventually the communication got there, but it took Romeo suffering for it to get there, which should never have happened. I think as well, just listening to the parents is a huge thing for me. He had so many different diagnoses, and no one was one expert on all of his diagnoses, whereas I was the expert on him. I knew him, I knew what he was like every day, and if I knew that he wasn't right, then there was something not right with him. So just to be listened to, because there were times in that journey where it felt like I was going crazy, like maybe I'm overthinking it and he's not as bad as he is, because I didn't have any validation. And then the last thing is relationship building. I think had Romeo have died in PICU when he went into organ failure, I would have probably been quite bitter about the whole situation, but having managed to build that relationship with palliative care and actually being supported has made me grateful that we've been able to have that 5 months at home with him, and I felt valued and listened to. And yeah, I think that relationship's really important, because the first time we met the palliative care doctor, we had a really negative view of them, and actually now, ending this journey, we think they're amazing. And I can say to other parents going through it as well that they're there to help you, they're not just there for the doom and gloom.